Project. Facciamo un grande Rambo! Yeah! Molto bene! E allora iniziamo prima di tutto ringraziando tutte le persone che sono qui. Prima di tutto, grazie ai genitori! Grande Rumble! Un grazie enorme agli zii, alle zie, ai nonni, alle nonne che sono qui! Un grazie ai bambini, bambine, alle ragazze e ai ragazzi che sono qui! Un grazie ai rappresentanti delle associazioni estere! Un grazie ai medici! Un grazie ai ricercatori e agli specialisti presenti. Un grazie alle aziende farmaceutiche presenti. Grazie allo staff di PaLaDIn Project Italia. E ora suoniamo insieme! Abbassiamo un po' il volume. Il tema di quest'anno è ogni cosa conta, everything matters. E quale metafora migliore se non quella dell'orchestra, in cui ogni strumento è importante per rendere ricca e meravigliosa la musica in ogni istante. Continuate a suonare, continuate, non smettete. Wow! Attenzione! 4, 3, 2, 1, stop! Yeah! E 1, 2, 1, 2, tutti insieme! Attenzione! 4, 3, 2, 1, stop! E tutti insieme! E 4, 3, 2, 1, stop! And go! 4, 3, 2, 1, stop! Oh, hey! Abbassiamo il volume. Abbassiamo un po'. Al mio via, io suono e voi ripetete dopo di me, ok? 3, 2, 1, me! Whoa! Whoa! Hey! Hey! Whoa! 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 1, 2, tutti insieme! Ok, abbassiamo leggermente il volume. Go on playing, go on playing. Tutta questa metà tra le mie braccia continuate a suonare. Go on playing. Tutti voi? 4, 3, 2, 1, stop. Qualche volta è molto importante sentire cosa stanno suonando le persone che sembrano lontane da noi. Call response. Voi continuate pure a suonare molto bene. Molto bene, attenzione, adesso facciamo un cambio, we change. Voi iniziate a suonare e voi smettete. 1, 2, 3, change. Segui loro. Facciamo un grande rumble. E 1, 2, tutti insieme! Four, three, two. Yeah! Allora, qualche volta la vita non è facile, no? Lo sappiamo, ma quello che fa la differenza è la forza che ci mettiamo. E per questo vorrei cantare e suonare insieme a voi un brano che viene dalla Rhodesia, quindi dal Sudafrica. Il brano si chiama Shosholoza. Shosholoza significa andiamo avanti. Nonostante gli inciampi, nonostante tutto, noi andiamo avanti. May I have a seat, please? Facciamo un call and response, quindi io chiamo e voi rispondete, ok? Shosholoza. Bene, but I would like to have more energy. Mi piacerebbe avere un po' più di energia. Shosholoza. Kule. Shosholoza. Kule. When you baleka. Kule. When you baleka. Kule. Shosholoza. Kule. when ya baleka, kule, shosholosa, kule, when ya baleka, kule. Okay, very good. Ok, now, ora dobbiamo imparare il finale, perché per ogni canzone che esiste abbiamo bisogno di un finale che ci dia energia per questi 2 giorni meravigliosi insieme, ma che saranno belli, intensi e impegnativi. Lo impariamo questo finale? Siete pronte? Pronti? Non vi sento molto convinti. Possiamo anche non farlo se volete. Fatemi sentire un po' di energia. Ok. Questa è l'energia di PaLaDIn Project che conosco molto bene. Il finale fa così, ne facciamo un pezzo per volta. Sarà 1, 2, 1, 2, 3, 4. Proviamo solo questo. Pronti, via. Ok, solo questo. Attenzione, adesso lo rifacciamo. 1, 2, 1, 2, 3, 4. E ora la parte difficile. 1, 1, 2, 1, 2, 3, 1, 2, 3, 4. Hey! Ok? Ve lo risuono. 1, 1, 2, 1, 2, 3, 1, 2, 3, 4. Tutti insieme. Ready, go. 1, 1, 2, 1, 2, 3. Yeah! Ultima volta. 1, 2, ready, go. Wow! So, il finale tutti insieme sarà così. 1, 2, 1, 2, 3, 4, 1. Lo rifacciamo, Lo rifacciamo un altro paio di volte così siamo belli carichi e cariche. 1, 2, ready, go. 1. Yeah! Sì? Show. Sì. Show. Siamo pronti? Rifacciamo il finale, dai, e poi cantiamo la canzone. 1, 2, ready, go. Mi raccomando, finale deve essere un urlo che ci portiamo dietro perlomeno per 3 giorni. Quindi dovete tirar fuori tutta la voce che avete e anche la voce che non avete. Ok? Do. Shosholosa Kule when ya baleka Kule Shosholosa Kule when ya baleka Kule Shosholosa Kule Sol when ya baleka Kule Shosholosa Kule when ya baleka Kule Shosholosa Kule when ya baleka Sciosciolosa Gule When you yabalega Gule Sciosciolosa Gule When you yabalega grande rumble per voi, un grande rumble per Jacopo che sta salendo. Vi presento, vi chiedo un grande rumble anche per le persone che sono qui. Abbiamo Marco al surdo, Giovanna al basso, Rico from Sweden on djembe. Grazie PaLaDIn Project, buona conferenza! Stefano Baroni. Yeah! Un grandissimo rumble, attenzione, attenzione, un grandissimo rumble, il più grande di tutti, per Jacopo!
Ci siamo. Mi sentite? Ottimo. Beh, davvero entusiasmante questo momento d'apertura della conferenza. Grazie Stefano.
Thank you very much, Stefano. I'd like to thank the PaLaDIn Project staff. Thanks for organizing such a great opening. Thanks a lot. Thank you.
Buongiorno a tutte e a tutti voi.
So good morning everybody. Welcome to the 21st PaLaDIn Project Conference. Well, many of you already know me, but let me introduce myself to you. My name is Jacopo Verardo. I'm 21 years old and I come from Pordenone, northern Italy. And I practice sport in Udine, which is a very energetic sport. All Duchenne boys might like practicing it, or at least watching a match. It's super cool, really. And I'm also enrolled at the University of Padova, where I live. And I am trying to find somebody helping me for my personal needs, but I travel by train on my own, sorry, as all other students who are not from Padua do. So hopefully all the DMD people in the audience will have this experience, which is a very good one. This will teach you how to live on your own, to actually savor the flavor of independence. I have come to know Parent Project for a long time. Actually, my family have always been very active in the fundraising activities and other similar activities. So I've been attending Parent Project conferences for a long time. So it's very nice to see that this is the first time that DMD person is here to open the conference. This is very important indeed because we all know that Parent Project is supposed to be a parent association. That was the case 30 years ago. The idea was to raise awareness about DMD also in the field of research. But now we DMD people, also thanks to Parent Project, have grown up, and therefore we may participate in making this true heritage for the whole of civil society. We're going to talk about research, about clinics, about daily life, and we're here to learn, to listen, and to be made aware of what is now going on in this field. But we're also here to talk about the disease, about its daily life aspects, and to allow the civil society to consider us not as unlucky people, but as people who are ambitious, who have some projects for the future, who have strengths and weaknesses like anybody else. Thank you all. Thanks for being here. Now, Ezio, the president of Parent Project, who's standing here next to me, will soon be telling you that we are all tokens of a huge puzzle that we can all participate in making up. And conferences, our conferences, are a very important part of this puzzle making. So enjoy the conference.
Grazie Jacopo.
Thank you, Jacopo. Well, there's almost nothing to add. You've been very good. Anyway, it is indeed a great emotion for me to open this conference, especially after Jacopo's words, for which I would really like to thank you. Thanks for making us even prouder to be here at this 21st Parent Project conference. I'd like to welcome you all, to welcome all the families, those who are here for the first time and those who have come back. I'd like to welcome also all the clinicians, researchers, and all companies. And special thanks go to our sponsor, Diamond, Italfarmaco, and other sponsors. Here is the list of them. I'd like to thank them all for financing us with your unconditional help. I'd like to thank thank all physical therapists, but also teachers. I'd like to thank them for being here, wishing to learn more about this disease and its relevant approach. I'm really happy to see so many people here. I'm very happy because DMD patients are the ones who are now asking their parents to take an active part in the association activities. This afternoon we're going to talk about drones, about affectivity and sexuality. I'd also like to thank all our, siblings because we have more and more people being a part of this group. We'd also like to thank our interpreters, Vanna, Alessandra, and their colleagues, because without their help, we would never make it to understanding what will be going on here. And by the way, all speakers are kindly requested to speak slowly so as to allow them to work at their best. Thank you very much. Interpreters thank the speaker, the president. Everything matters. We're all part of one whole harmony. This is the catchphrase that has been chosen for this conference. Everything matters. We're here as tokens of one single puzzle. We are all necessary, and we have been so up until today. I mean, patients, siblings, clinicians, parents, researchers, companies, the Parent Project staff. I wish to thank them all from deep in my heart. Their daily work is amazing, especially in preparing this conference. Many of them, well, you'll meet them today, but you may have also met them yesterday, for example. Many of them work behind the scenes, so to speak. I wish to thank them all, including precisely what Parent Project is about. It is a huge puzzle in which every token plays their role. Starting from us, parents, we are irreplaceable. I am one of them, and I'm not one doing voluntary work. Of course, all those who do so are to be warmly thanked. But we are parents, and each one of us is supposed to do something to work for a common cause, to stop DMD. And for that, we need to take care of our children, to make their quality of life better, and also to do the same for us parents and our families. We all feel like we want to listen to our clinicians and researchers. It's an honor for us to have them. And we're here again after 1 year to listen to the progress that has been achieved so far. It is true that the quality of life of our children has definitely improved, which is particularly thanks to them indeed. But I'm also sure that without our association, this would have taken much longer. But we are here to take the first fruits of research of Morolon, substituting the cortisone, but also divinostat and ataluren. They are also all, tokens of our puzzle. And then let us talk about our counseling centers. They play a very important role here, because once you know that about the DMD diagnosis, you as a parent need to count on the professionals that may accompany us parents as well as all of our children, not only our DMD children. This is really what can make a difference. So please follow us on our fundraising campaign that will be introduced later on. You'll get the brochure about it well, you are getting it right now. This year, unfortunately, our Easter campaign will not take place, I'm afraid, but in a more, in a longer-lasting framework, we can support our association in a different way. So you'll get more about this in the brochure. Ilaria, Zito will now take the floor to introduce the first scientific session, but before that, Cristina Piccolo will now take the floor to tell you how to donate if you so wish. Thank you very much. Enjoy the conference.
Buongiorno, benvenuti.
Good morning. Welcome, you all. Welcome. Thank you very much for being here. I would also like to personally thank Stefano and all his band. And of course, I must thank Jacopo.
Vi stanno
So you are actually getting the brochure with all the indications and the information about our fundraising campaign. So we ask you to please not leave this conference without donating. Well, many of you already know about the relevance of this specific puzzle token that is a DMD counseling center. It is of paramount importance for all families getting to know the Parent Project Association. Right now we have 8 counseling centers. You'll find it all in the brochure, including a map showing where they are actually based. And we definitely want to keep going on with this activity, if not making it even better with a larger amount of professionals working in them, so that all DMD families may actually, once they need it, find someone within these counseling centers to help them. And for that to happen, we need you all. And for that, we need you all to donate continuously, so to speak. So I've tried to make, short computation. There's 500 people in the audience. So if 500 people make this choice, and I'm sure this is what you will do, by the way, this is the form that can be detached for filling it in. So starting from 9:30 today, you can fill it in, but you can find Emilio at one of our desks, who is ready to give you all possible information for the modes of your donation. But you will not leave the conference without doing that. So let me tell you, if each one of you chooses to donate, say, 30 euros per month, so €1 per day, basically, well, just the 500 people who are at this conference will help you raise 15,000 euros every month. So, and if you then go back home and find, I don't know, a neighbor, a friend, your husband, your wife, a cousin, a colleague at work who might want to do the same thing, well, that would add to 500 people more, so 15,000 euros more, which may well help change the life of DMD or BMD patients. So please sign in. Thank you very much.
Scusate la parte fondamentale. Con estrema
And now, we are even, I mean, we're running perfectly in time, if not even, in advance of the time envisaged. So it seems like we're 10 minutes early. Well, you've all been so very good at being here on time. So Ilaria, Zito, you can come on the podium, and the speakers are also kindly requested to come to the podium. So let me take this chance to introduce you to our Auntie Ila, Dr. Ilaria Zito from the Scientific Bureau of Parent Project. She's a biologist, has been working with Parent Project since 2018, and she's also in charge of the patient registry. You'll hear about that. And she's going to be the chairperson of our first session about strategies during the early stage of development.
Mamma mia, quante emozioni già di prima mattina.
Well, very early in the morning to go through all that. I wish to thank Stefano and the musicians for starting the session in this incredible way, and I wish to thank Jacob also for his words that are really special. We are very glad to see you all here, all wearing this red T-shirts. Well, I start the session. I wish to invite the rapporteurs to come over to the stage, Valeria Sansone, Claudio Bruno, and Stefano Previtali. And thank you for being here with us. Thank you for accepting our invitation. And just a couple of introductory points. We have a new organization for the scientific sessions, and so these sessions are organized according to of the different drugs, as was the case in past years where we were following therapeutical strategies. So we know that we know that the route of a drug is quite long and also extremely difficult. It is not always crowned by success, as many of us personally know, and it is made up of a number of phases, of stages. You have lab testing on cells, on animals, and then there are all the other stages that follow each other, provided the former phase, the former stage has been successful. And then you assess the treatment on an increasingly high number of individuals and assessing a number of things. First, safety and tolerability. Of course, they come first, and then gradually efficacy, optimal dosing, and risk-benefit ratio. And if you reach the end of phase 3, and there are very few drugs who are that successful, when you get there, then you ask for the approval of the drug, of that experimental drug, and then there is a further stage of pharmacovigilance. Today we have 3 sessions considering all the updates on clinical trials, and they have been divided strategies at an initial stage of development, then intermediate strategies this afternoon, and tomorrow morning advanced strategies. In this first session, we will be consider strategies trying to restore dystrophin, so gene therapy, new generation exon skipping. And we are really moving forward, and we learn from failures and successes, and molecules are optimized, hoping we can get to something that is truly better so that it can move on to the clinical phase. At the end of these three presentations, we have a Q&A session, and I'll call here all the people who are in charge of the different clinical trials. There are many molecules, so you can jot down the questions, and you can then ask the questions speaking in the microphone, or you can send them to WhatsApp to this number, and that applies both to the persons who are here and also to those who are following us from home. Please speak slowly to guarantee the translation. Thank you, thank you, thank you very much indeed. And now I give the floor to Claudio Bruno.
Le giro qua,
Sì, le giri qua e loro adesso.
Buongiorno a tutti, sono Claudio Bruno, Istituto Gaslini di Genoa.
I'm Claudio Bruno from the Genoa Institute, and after listening to what we have heard from Jacopo, and that is the most beautiful message we can sort of bring home, I have the task to open this conference, this sort of family reunion, as I like to call it. So I'll try and be extremely simple, and I'll try also to speak slowly, as I was asked to do. And my task is speaking about some drugs that are at a very initial phase. These are my disclosures. As many other colleagues, we are principal investigators of a number of companies. I had prepared a slide that is, in my opinion, very important, because that makes you understand what are the different phases of development of a drug, and also how many years are necessary to be able to have a drug in a phase 3 trials where your boys can have access to. So you must take into account what is being done upstream in terms of technology, in terms of economic investment, in terms of testing on animal models, on cell models, and then also the regulatory aspects. So in general, I've always had the feeling of, yes, great enthusiasm, but also intellectual honesty by companies, because, as you perfectly know, many of these testing had to be discontinued because they did not reach the appropriate prerequisites, especially in the initial phases. First and foremost, safety, and safety again, and then efficacy, and then a number of other items that must always be taken into account. And then there are the regulatory authorities in the United States and in Europe. The United States have different rules, and so sometimes there are drugs that are approved in one continent and are not approved in another. So I'll speak about molecules that can restore the production of dystrophin, and a strategy that is called exon skipping. To repair the genetic mutation has to have a restoration of dystrophin. You can find these slides in the brochure that you'll find here, or on the website that is extremely exhaustive. I will invite you to read the website. Exon skipping is a technique which will enable you by molecules that are built in a lab, that are engineered. Well, they prepare small DNA molecules that bind to fragments to try and mask some exons so as to skip those exons when there is the protein translation moment. This technique is called exon skipping, and there is the possibility of skipping, of masking, so to speak, some exons. Well, that gives the possibility of many deletions to be solved by exon skipping. If you skip exon 51 and 53, we have 48 possibilities, 48 different deletions that are listed here, and there is a high percentage, and that in general there are situations whereby through this approach you can have a therapy, well, of course, an experimental therapy. 51 and 53 are already used. They are studies approved in the United States and also in other companies in Europe. During the day, mention will be made of exon skipping by other companies. I will show you some preliminary data of these three companies, Dyne, PepGen, and Wave. They are all in the US. I will show you 5 slides per company. Dyne, I have translated everything in Italian so as to facilitate your understanding. And they developed a platform, so a technique, so that these molecules, these oligonucleotides we know a lot about already. So this oligonucleotide can reach the gene in the best possible way. In all these approaches, try to improve the entry of these oligonucleotides in the cells. And Dyne has developed a very specific molecule. This molecule is muscle specific, and the system is based on a strategy whereby the oligonucleotide, the blue thing, PMO, with a bilinker system links to an antigen, and the antigen enters the muscle via a receptor that is present on the muscle membrane, not only the skeletal muscle, but also the heart muscle, and also the diaphragm, that is extremely important. So these are the strategies. So we want these molecules to enter the cell in an effective way, and so they can penetrate effectively, and so as also to optimize the time interval between administrations, so as to avoid having administrations that are very close to each other. So we want to reduce the number of administrations with substances that can work better. So this is the preclinical phase. And here we use a cell model, animal model, the classic lab mice. We have an animal model that is the DMX mice. It has a defect that is slightly different from the human, and so in this case the platform was set up for exon 23, and there we had very encouraging results. as to the increase of dystrophin that we can study by studying the muscle, by studying muscle biopsy, or by studying the protein with a specific lab technique that is called Western blot. The preclinical phase gave rise to a lot of enthusiasm, and so phase 1 and phase 2 trials were started in children aged between 4 and 16, both ambulant and non-ambulant, with the dystrophin gene deletion that was susceptible to the skipping of exon 51. There are 3 phases, and we have ascending doses. So the molecule initially you use different doses of the drug to try and identify the best possible dosaging. The administration here is carried out also with a placebo, and it is done once a month, so once every 4 weeks. When they speak about primary and secondary endpoints, well, by that we define the most important things, the things that are to be then submitted to regulatory bodies. So the endpoints we expect from this drug, the endpoints must be reached and demonstrated in an objective way. So here, safety, tolerability, well, these are the primary endpoints, as well as the increase in the levels of dystrophin in the muscle. So, safety. So you look for adverse events, and well, they can be minor or serious adverse events. Most of these drugs may, for example, lead to fever or gastrointestinal problems, nausea, vomiting. These are not considered as major events, and they are present, let's say, in 10%, 5% of cases. And here we have not had, we haven't had any issue with other organs. Of course, we test them as well, and we have also seen that after 6 months with a biopsy, we have seen an increase in the percentage of dystrophin when we carried out muscle biopsies. So then we examined, the company examined this data in December 2023, and so we were able to demonstrate the safety of this drug and this presence of dystrophin, the increase in dystrophin. And this drug is being administered in 5 centers in Italy that are listed in this slide. The molecule here is called PNG-ED051. There again, it is a special platform. EDO means enhanced delivery oligonucleotides. So the molecule is helped to move better, to be more easily transferred, and a better spreading in the tissue. So the preclinical phase involved mice, but also monkeys, so non-human primates. And here we had administrations and studies of muscular biopsy showing an increase in exon skipping, an increase in dystrophin, and also a distribution of the drug, as you see in the monkey model, in different muscles, including the heart, so the cardiac left ventricle and the diaphragm. And here we had a phase 1 in healthy volunteers, adult healthy volunteers, about 30 people. We administered the molecules, then we carried out a muscle biopsy. And here you can see that the presence of exon skipping And here, with different doses, after 10 days and then after 1 month, you see what happens as far as exon skipping is concerned. Beginning of January, we carried out the dosing of the first patient in Canada. And this is a therapy that at present is being carried out in Canada only. So this is a therapy envisaging an administration once every 4 weeks for 3 months, and the primary endpoints are safety and tolerability. We are at the very beginning, but in 2024, we may have the inclusion also of European countries where we may carry out a randomized trial with children above age 8 with both ambulant and non-ambulant with a deletion that is acceptable to the skipping of exon 51. This is another molecule. This is the WVEN531. It is a special peptide that can better penetrate in muscle cells, in myocytes. Preclinical phase, animal models, cell models. At the cell model, we have 70% recovery of dystrophin, better survival in the mouse model, and then an increase in the concentrations of the molecule in the monkey. And here with good findings, good numbers also in the heart. And so these findings supported the idea that we can open up a trial also with children. Phase 1-2 was started only in 3 children, 8, 9, and 10 years of age. And here they were ambulant children, and we had an increasing dose where we checked safety, tolerability, and as secondary endpoints, the changes in dystrophin and exon skipping from baseline to and then various intervals of time. In these children, we did not have special adverse events, so the molecule was thought to be safe and well tolerated, and we had a good concentration of exon skipping after 3 doses. So, and this is an ongoing trial. The name of the trial is Forward 53. So children aged between 5 and 18, both ambulant and non-ambulant, and of course with exon skipping 53. And this is the design of the study. There is a muscle biopsy at 6 months and then at 1 year. And primary and secondary endpoints are similar to the former ones. So the importance essentially of safety and tolerability. This is a summary of the studies, different companies, different platforms. So chemical trials, mechanism of action, the names of the molecules, and what are the age groups, type of administration, and then down below the countries where these trials are underway or are planned. Thank you. And of course, companies wanted first of all to thank, we wish on their behalf, I wish to thank all the families and the children for their willingness to cooperate. And I'd also like to thank personally all the families and all the children, parents and grandparents. We feel very, very close also to grandparents. And of course, also Parent Project and all the other associations. So I join my thanks to the thanks of the companies. And now I give the floor to Valeria Sansone.
Buongiorno, grazie. Rimango.
Good morning. Thank you very much for being here. Let me start by saying how happy I am to be here with you all. Well, we've been working with Parent Project for quite a long time, namely because they make complex things, simple. And it is never easy to talk about these molecules in a way that everybody can understand. But we can make it apparently. So the possibility to convey this kind of message in a simple way is very good for us, also because this helps us to actually share with you the difficulties that we may run into when working with these molecules. Sometimes, caution is to be chosen, but other times, everything we experience must indeed be shared with you all. So I work with Dr. Albamonte. He is a child neuropsychiatrist. You may have already heard about him. I'm also going to follow this positive trend, namely in saying that it's nice for us to know that many molecules are out there for us to use them to the advantage of a larger and larger amount of people that may indeed be benefiting from them. So this is just to convey a positive message. What very often happens is that many of you might feel, neglected and put aside from the rest of the research. But let me tell you that there are many more molecules that are now around for us to use them. So it's a somehow positive message that I want to convey at this stage. Now I'm going to talk about BioMarin, these three studies that you see here with three different molecules that are now being studied. Let me try to start with BMN 351, which is used in the studies phase 1. So basically, the point is to try not to produce any damage and test the efficacy of this molecule. It's about the exon 51 skipping. It is administered intravenously, and it seems to be a bit more specific than other approaches, especially regarding what Claudio just told us. It seems from the relevant preclinical trials that it may be more stable. Again, its administration is intravenous as compared to other usually subcutaneous modes of administration that children may not always appreciate. So that entails a weekly intravenous injection of the molecule. Of course, blood testing, some ECGs now and then, again, but the same goes for some neuromotor tests. You know that some at least standardized tests should be carried out. 2 muscle biopsies are to be carried out, and it's usually a day hospital approach, but sometimes they might have to stay overnight. So the initial study will have a length of 17 months, and if safety is confirmed, then we may have an extension study following this one. Now, just to recap this part of my talk, let me tell you that we start with the minimal dosages, and then, of course, dosages might be escalated until we get to a dose that is considered as the safest one in terms of the cost-benefit ratio, and then longer time follows. There's no placebo here, by the way. I might add that might have made it, all more difficult. Now, part 2, we start very cautiously, as I said, then cohorts get larger and larger, and there's a dose escalation. The idea is to optimize the use of biopsies as much as possible, trying to make this, less invasive. Unfortunately, we need to carry out, to have these biopsies, but we want to make that all, the least aggressive as possible for the children. So these are going to be ambulating children with mutations where exon 51 skipping can indeed be the case, and then we want to reach our target basically with as long-lasting molecules as possible. This is our basic aim right now in our preclinical trials. Retrieving dystrophin, which is our main goal, seems to be quite encouraging since it seems to go hand in hand with the possible indications of very encouraging data and more encouraging data to come. Now, let's talk about the Entrada study, where the approach is a bit different. This is about the skipping of exons of 44 and 45. The approach, however, is always the same. That is to improve as much as possible the passage of the drug in question into those cells that we want to be reached by the molecule itself. That is why we use an endosomal escape vehicle known through its acronym EEV. Well, the mechanism is a natural one, is a physiological one, so the membrane is actually included. You can see it here. You see that the molecule that is employed will basically exploit a physiological approach of the cell. Some vesicles are formed, but they are more stable in the NK host, in a more longer lasting way, the molecule that can therefore enter the cells we want, of course, to be entered. This may indeed pave the way to longer lasting studies. Now, what can this system bring about? Well, basically, molecules whose weight may vary. Right now, for example, we're interested in having very tiny fragments of genes whereby to retrieve dystrophin. In preclinical trials, we have very encouraging data, and that was for exon 45, by the way. But the same goes for exon 44. In this case, we use the multiple ascending doses. So we start from the smaller ones to the ones where the cost-benefit ratio turns out to be the best. Once again, the main goal is, of course, to reach a good degree of safety and tolerance. And to that, neuromotor testing as well as cardiorespiratory testing are essential. Preclinical trials are quite encouraging here too, both in terms of the quantity of the actual skipping, whereby there's a good percentage of dystrophin that is retrieved, but also in terms of the relationships with the actual testing. We don't want to stick to the lab. We really want to see what happens to the actual functioning of the person. And since such mechanisms can easily be transferred to, for example, monkeys and therefore to humans too, well, then we might well think that this can bring us to a good degree of success. So phase 1, we're moving on, of course, always within the framework of this phase, so that apparently in this very year we might move on to larger cohorts. And these are the preliminary data regarding efficacy, both within skeletal muscle cells and within the heart, in a dose-dependent approach to dystrophin retrieval. So there's a good relationship with the testing. The more we administer, the better the functioning turns out to be. And to conclude, let me tell you something about the avidity study. It's a more advanced study. We are in phase 1 and 2, and it's about exon 44 skipping. Here we go back to a previous approach, if you wish. Well, it all orbits around receptors. We have a muscle-specific receptor that can be found in both the skeletal and cardiac muscle cells, but also in the respiratory system. So we use, of course, the specific molecule, a specific molecule that we want to enter specific cells. So depending on what we match in the conjugated azos, because at first we had non-conjugated oligonucleotides that had a delivery issue. So the issue was how they reached the cells we wanted, of course, to be targeted. But then our team managed to make these oligonucleotides conjugated so that now they are matched to some carriers or antibodies, whereby they can much better target the cells we want them to enter. These are preclinical data. Well, there's a 60% of exon 51 skipping, both non-conjugated and conjugated, over 50 times. Yes, of course, the exon is not exon 51, it's actually exon 44. Anyway, the study in question is called EXPLORE. And in this case, administration takes place intravenously, and in this case, we have a placebo group, although in the later phase that may reach to an extension study, the placebo group will not be included. So we also have a multiple ascending dosage approach here. And Of course, safety is to be considered through the proper motor functioning testing. The skipping amount was quite good, so it was quite successful. And by the way, here we're talking about phases 1 and 2, so safety, tolerance, adverse events. Well, data seem to be quite encouraging, so we seem to be now able to move on to other, to further phases whereby to include more patients. So we believe we are now going to move on to clinics. It seems like stability is quite good. Maybe intravenous administration may not be carried out every month, but maybe every 6 or 8 weeks, which is not a huge difference, but at least it tells us how quickly we are moving to making these molecules more stable and the whole approach less aggressive. Thank you very much. I'd like to thank the families, the children, our staff. Okay, but families are indeed of paramount importance. I do hope that we clinicians and researchers will at last understand that it is very good for us to work together with you when we are to choose a molecule or another one. So there is no conflict of interest on our side. So in case you see we're having difficulties in conveying our message, is simply because these are beautiful moments, beautiful times, but we're here together for the better and the worse. Thank you.
Buongiorno.
Good morning. Thank you for inviting me. It's always a great pleasure to be here with you, and also for this energy-loaded beginning. I hope I can keep you awake for the next quarter of an hour. These are my disclosures, and these are the 3 studies I want to talk about. The first 2 are gene therapy, whereas the last one is cell therapy. I start with gene therapy. This is by Regents Bio. It is this company is based in Maryland in the US, and the first 2 studies work on microdystrophin and viral vectors so as to carry the microdystrophin in the muscle. And as for the first 2 trials, we need transporters of genes inside the cells of our body. This is easy with small genes and is more difficult with big genes, because with these transporters, these viral agents do that, but it is as if you were to move your furniture and you just have one lorry, and you must put in that lorry what is most important. You can put, I don't know, the bed or maybe a wardrobe, but then you must decide whether you want the TV or your bookshelves, and you must decide what you want to carry on the only lorry. We have a very big gene, but we can transport only a part of that gene on this carriers. So we must decide what we want to carry. And we have looked at the largest deletion. This is the second line you see there. Here we are speaking of the Becker phenotype. And then on the basis of the gene, of the remaining gene in these Becker patients, we have engineered microgenes of dystrophin so that these viral vectors can carry this microgene to our cells. We need a microdystrophin. So there is a limit there, so you don't have all your furniture, so to speak, but just some of it. And we use as a transporter, as vector, AAV8. These are the viral agents that target the heart muscle in the best possible way. And then we have the promoter. The promoter is a sort of operational system so that the gene can be expressed, and this works very well in the heart muscle. And then they put this terminal portion of dystrophin that is not present in other microdystrophin, because since this binds better to the sarcoplasmatic membrane interacting with the proteins there, that can be more stable and so provide an advantage. They have reduced the CPC sequences that may have a role in the immune response. When you introduce a new molecule in the body, you may have an immune response rejecting the new molecule. The clinical trial is called Affinity. It's an open-label trial, so all patients receive the therapy. It is a phase 1-2, so first you check safety and then efficacy, of course. Patients included in this study are between age 4 and 11, and we considered mutations above exon 18 because with other trials, we have seen that patients with mutations in the first exons, especially between 8, 11, and 18, well, you may have there a very important immune response, a very aggressive immune response, because these constructs are built up in such a way that if the patient has that mutation, the patient will react in a very aggressive way. The immune response would be very aggressive. That is why we have chosen patients with mutations above 18, must have ambulant children, so more than 100 meters, and they don't have antibodies versus the viral vectors, because otherwise the immune response would be too strong. The trial is carried out in such a way that patients start with initial immunosuppression. So before starting the drug, they take corticosteroids and these immunosuppressive drugs for about 3 months, so as to avoid immune reactions. The trial goes on for 12 months. After 3 months, there is a biopsy, and then checks are carried out every 3 months. So the primary endpoint are safety, and then the other endpoints are, the different tests such as the North Star, the NSAA, level of microdystrophin in the muscles. So you carry out a biopsy before and after, CK levels, NMR, and heart and muscle NMR. The trial started in the US. There is a first phase with 4 patients. The first 2 patients with a lower dose, you see there, and then other 2 patients with a double dose. 5 patients, in fact, 3 with a lower dose and 2 for the higher dose. So we have 5 patients at the moment. These are the numbers, age, weight. At present, the trial is only in the US, but the company said that if they have good results, the trial will be extended to other countries, possibly including Italy. These are the first findings on the patient. Safety is good. We have 9 months trial. The first patient was treated in spring last year, and the first efficacy findings on the first 3 patients. You see that in the first 2, the expression of dystrophin at the Western blot is consistent in one patient. One patient is 38, in another patient is about 11%, in the third patient 83%. There is a reduction of CK of about 40% in the first 2 patients and 90% in the third patient. So the data are pretty good. Here you see the biopsies at 3 months. You see a good expression of dystrophin, exactly where it is supposed to be present. So whether there is also laminin that interacts with the dystrophin. These are the contacts of the company. You can write to the company directly. The name of the trial is Affinity. The second trial is Solid Biosciences. There again, an American company. This one is based in Massachusetts. Here again, it is a microdystrophin. We are a bit more backward there, so this just started as for the clinical part. This is a variation of rather a variant of AAV9, because in animal models they have seen that this one can reach both the muscles and the heart. The promoter is CK8, and the microdystrophin here has exons that codify for the region binding nitric oxide, so that reduces hypoxia during contraction. So it is supposed to protect the muscle during the contraction, so avoiding the muscle to be damaged. Here again, animal models, and you see that if compare the normal AAV9 vector with the new vector, the presence of the virus is much higher with the new vector, both in the skeletal muscle and in the heart, and far less present in the liver. So it goes exactly where we want it to go, and the quantity of dystrophin produced is higher, and that as well. And as for the CK level, go down and are lower than CK if dystrophin is transferred with the AAV9 vector. Here you see clearly the portion of microdystrophin we are interested in, and as for the strength in these animals, we see that the strength improves with this vector if compared to the former one. They also carried out trials on monkeys. Here there is an advantage in the distribution in skeletal muscle and in the heart, and it is far less present in the liver. This is a clinical trial, phase 2 clinical trial. It is an open trial. You saw 4 or 5 patients, age between 4 and 5, the weight below 18 kilos. They must be ambulant. They must not have antibodies, anti-AAV9, with and mutations between 1 and 11 and 42 and 45 are excluded. They will receive corticosteroids for the immunosuppression, and there will be 2 centers in the US for this first part of the trial. If everything runs smoothly, well, we will have new centers in Europe and certainly in Italy. You see the dose, primary endpoint, safety, efficacy with biopsies. Here we have 3 biopsies, baseline, 3 months and 1 year, to check for how long the dystrophin stays there, and then movement tests as usual. These are the contact information. This is the contact information of the company. Last trial on cell therapy at the San Raffaele Hospital, and that was devised by Professor Cosso. I will speak of the clinical aspects of this study. This was partially sponsored by the San Raffaele Hospital and the Manchester University, where Professor Cosso is at present. I will call them stem cells. They are precursors, in fact, but they derive from the vessel walls, and they keep their ability to form muscle. If you put them in a special condition in vitro and in vivo, they turn into myocytes. They were engineered in such a way as to produce an mRNA capable of doing exon skipping of exon 51. And this, in this case, is just a cell doing that. This is done through a lentivirus. You infected the cells with a lentivirus, with a promoter, the F1 alpha, and the cells produce this nuclear RNA to induce the exon skipping of the other nuclei present in the fiber, and we hope that the cells may get in there when they are injected in the patients. These are trials by Professor Cossu. Here you see that in vitro these cells are capable of producing muscle tissue if they are injected in a mouse. The damage is repaired, and in the dog as well you have a good expression of dystrophin if these cells are injected in the animal to produce dystrophin. We have used these non-engineered cells that they were used some years ago. The paper was published in 2015, and there we injected cells taken from compatible donors, essentially the siblings, and they were injected in the patient's arteries, and in this case we hoped they would reach the muscle and that the muscle could be repaired, as was the case in animal models. The trial appeared safe, but unfortunately the efficacy results were not good, so the quantity of cells reaching the muscle in men are too few. The quantity of dystrophin is minimal, and the production stops after a short time. And after a few years, Professor Cossu thought that they could engineer the cell to do exon skipping, and the cell enters the nucleus and sort of informs other cells. So even if just a few cells get in there, they can produce a sufficient quantity of dystrophin to solve the problem. That was shown in vitro. If you have a look at this Western blot, this is the normal dystrophin that is produced in the cells of a healthy patient, and this is the dystrophin produced in cells that were engineered, so cells of a DMD patient that contain this nuclear RNA, and then they're capable of producing dystrophin. And even if there is a dilution of 1 to 10, the quantity of dystrophin still increases significantly if compared to a healthy cell that is put together with other 9 cells that are not healthy. And also animal trials were carried out. In the animal as well, there is a quantity of dystrophin being produced that is comparable to that of a healthy patient. So very soon we'll have a proof of concept study to see if the thing works. So you enroll 5-6 patients, non-ambulant patients, and to see if in a muscle of the foot, the extensor digitorum, and that we don't use a lot, but so this muscle is very well preserved. Normally, we take this muscle, the cells will be taken and engineered, and then these cells will be re-injected in the contralateral muscle. And after 2 months, we will again take the muscle and see if there is a production of dystrophin. If we see a production of dystrophin higher than 10%, we'll use it on the flexor muscle of the thumb, because this is something we are very interested in. And then if this thing is effective, we will have in the future another trial for systemic administration. At present, this trial is being carried out at the San Raffaele, and then we'll see how we can go on. If there are patients who want to participate in this study, please get in touch with us. I wish to thank all those who work with me, and thank you, and we are here for all your questions.
Grazie a tutti e tre per 3 presentazioni veramente.
Thank you all. Thanks a lot. You've all been very clear and highly specific. And now let me please let me ask Professor Giulio Cossu to come to the podium. He is indeed the designer of the study we've just heard about, and the representatives of the different companies, Dugar from Dyne Therapeutics, Michael Oldham from Entrada, Tommasi from BioMarin, and then Bioscience. And by the way, there are three people that are following us online, Marcos, Tami, and Asgir. Thank you all for being here, by the way. I would particularly like to thank them, to thank the people who are with us online, because it's, nighttime where they are. So welcome to you all. So, as I said, this is indeed an initial phase of development, but all these studies seem to have taken us to an improvement of the general situation in terms of the exon skipping, for example. Much has been improved in terms of administration, for example, which plays a key role for families, as we know. And we're going to ask Giulio Cossu about his study. I understand a new virus is being used for allowing the therapeutical agent to reach the cells. So maybe you'll tell us something more about that? Okay. Just in 1 minute. Well, the virus is not a new one. It's used for several genetic diseases. We have simply introduced a small RNH whereby we have exon skipping. So we have used cells as Trojan horses, basically. So one of the reasons behind the non-functioning is that sick cells cannot be removed, as it happens with the marrow or the epidermis. So in a patient treated 10 years ago with the best possible colonization, there was less than one, healthy cell out of 100. So we decided we should try to engineer cells so that once the nucleus is in the muscular fiber, one genetically healthy and say 20 or 30 that are not healthy, the small RNA may also enter that cycle. So we can see 10-fold retrieval of dystrophin, which may tell us that the problem of colonization may be much better tackled. You will never reach an 80% otherwise. Thank you very much. Any questions from the floor? Would anybody like?
Numero di telefono che
Okay, any questions from the floor? So you can also, write your question using a WhatsApp number. Well, I have a question for Professor Cossu. So administration is topical, right? I mean, the mode of administration is the local one, the topical one. So anything else for us to know regarding the future? Well, okay, 10 years ago when we started our experiment, all relevant problems or issues going hand in hand with not blood cells being used had already appeared. So now we know that we are not going into, incurring in any surprises, bad surprises, so to speak. We're very happy to see, in particular, the 44 exon skipping. So far, we've only orbited around other exons. So I would like to ask the people from Entrada and Avidity whether this is also going to happen here in Italy.
happy to start. Thank you, everyone. Michael Oldham from Entrada. Very excited. Yes, thank you to be here. This is our first Parent Project Italia meeting, so thank you for hosting us. We also are very excited about our exon 44 and 45 programs, and we are looking, as we move into studies in patients, to have sites globally, and are evaluating sites here in Italy, yes.
Very well. And how about Yvonne?
I'm not sure that I quite understood the question.
Arriveranno gli studi.
Okay, the question is this. The exon skipping 44, will they also reach Italy? Will they also be the case here in Italy? Can you hear English translation?
Right now, we are only conducting the study in the United States, but we'll keep you guys updated, definitely, if we are expanding into Italy and ex-US countries.
Ok, molto bene. Allora, no.
C'è una domanda che è arrivata sul numero.
So we got a question from the WhatsApp chat. The question is the following. What is the percentage of dystrophin that is produced as compared to exon 51 and exon 53 skipping procedures? And please, once again, raise your hands in case you want to ask questions.
Chi vuole cominciare?
Anybody wishing to answer? Anybody?
Yes, hi, this is Ash from Dyne Therapeutics. It's nice to see all of you again. I've been here for quite some years, and it's nice to see some old friends and make some new friends. So thank you for having Dyne at this meeting. First of all, before I answer the question, or try to answer the question, I just want to thank Parent Project Italy for having us here. And then also we're very fortunate to have 3 of our investigators up on the stage here with Professors Previtali, Sansone, and Bruno. And then we also have Dr. Marcapane, I think, in the audience as well. So we have several sites for the Dyne phase 1-2 study in Italy, and we continue to expand. If I understand the question, it's how does maybe the dystrophin expression compare with previous technologies? Is that correct? Yeah. So as many of you have seen Dr. Bruno present, we have our preliminary data from our low-dose cohort outside of the US that has shown an increase in dystrophin production at 6 months from baseline. And so we showed an absolute value of about 0.88% normal dystrophin in our 5 mg per kg PMO equivalent cohort. So we were very pleased with seeing this level of dystrophin production at this lowest dose at 6 months, at only 6 months. And as you may know from the literature, there is an accumulation of dystrophin seen with other programs, even doubling out to 96 weeks. So we really hope to see that these levels increase over time. We expect them to increase over time. And as we get to our higher dose cohorts, 10 milligrams, 20 milligrams, 40 milligrams, we are hoping to see sort of that 5 to 10% dystrophin restoration at a 6-month time frame. And then, of course, accumulation over 1.5 years or 2 years with chronic administration. We are dosing every 4 weeks, and we will be exploring even less frequent dosing. So, I'll have an update hopefully in the coming months, but hopefully we can get to even every other month dosing within this particular study. So we're exploring different doses and dose regimens.
Siamo molto felici di questo, anche dei.
We're very happy about this. Thank you very much for such a less frequent dosage approach.
You can.
Yeah, so
My name is Isela. I represent Wave Life Sciences. Similar to what Ash has described, our Part A study demonstrated a 0.27%, a small percent expression of dystrophin just after 3 doses of 10 milligrams per kilogram amongst 3 patients. Now, considering our preclinical animal models, it had shown that prolonged, sustained exposure should eventually show an increased expression of dystrophin, and that's exactly what we're trying to do with Part B, where we will continue to dose up to 10 patients up to 6 months and beyond to see if we do get an increase in the percentage of dystrophin.
Grazie.
Yeah, can I ask one question, please? So, hi, thanks for inviting me here to the conference today. I just wanted to highlight that similar to my colleagues.
Non sentiamo molto bene, non so le traduttrici, no, le interpreti.
A high increase in the exon 51 skipping from our phase 1 clinical trial in the healthy volunteers, and that was for a single dose administration. We have seen an increase that ranging between 1.4% up to 2% based on the dose level that was given to the healthy volunteers. So what we are looking for in the current time in the DMD patient, in the Connect-1 study, that we are hoping to see the similar reflection in the exon skipping along with the dystrophin as well.
Bene, grazie. Dal pubblico, benissimo.
Yeah. Hi. This is specific for project. First of all, I have to be that I'm excited that finally moved to other exons instead of just 51. Secondly, I'm also excited that I see that these projects are include up to 27-year-old boys. My question is, what it is expected, the benefit for older boys like the 27-year-old or maybe 30-year-old from this exon skipping procedure or even gene therapy procedure?
Domanda molto interessante. Chi vuole rispondere?
Excellent question. Anyone who wants to answer? For those who have trials on older children.
I can speak for Wave Life Sciences. So, as you may know, our Forward 53 study is targeted for patients aged 5 to 18. But clinical development is an iterative process. So you need to gain, as you gain more data, you get more confident in, well, what further you might be able to do. So right now, essentially, we are still at a discovery stage. So unfortunately, I won't be able to provide a solid answer to that. But what we hope to do is to gain enough data from existing trials to see, how to position further drug development or reposition existing drugs for the older patients.
So it's a great question, very difficult question. I think many of us have hopefully similar thinking around the new modalities, the new technologies that all the companies are developing. One of the big challenges has been getting the exon skipping drugs into the cardiac muscle, into the heart muscle, into the diaphragm to be able to affect respiratory function. So hopefully, with these next generation technologies that you're hearing about today, there will be the ability to affect those long-term changes in terms of cardiac function, respiratory function, so that even if these young men are treated later in the stage of the disease, that there can be benefits in terms of the cardiopulmonary effects.
Sì.
Un commento clinico.
A general clinical comment. Well, certainly now we are convinced that the earlier we start when we're speaking of a pathology that, of course, goes on worsening, the sooner the better. I believe we all agree on that. And we are at a time of true exploration, and there are two important issues: how to reach the target and how long does the effect last, and then reaching not only skeletal muscles but also respiratory muscles, heart muscles, and there are various molecules that are trying to approach this problem. As to the translation of some experiences where we have patients that are older, where we are testing some therapies, well, of course, we will have a new phase in the trial. At present, we are concentrating on the heart and on the diaphragm, but then we must try and understand what is clinically significant. In older patients, we won't be speaking only on the restoration of dystrophin or what we obtain in lab. I mean, from the strictly technical viewpoint, we'll move on to the most important aspects. Of course, breathing and the heart, and that is the main center of attention for all of us.
Permetto di aggiungere che sono in linea con quello.
I agree with what has been said so far. For all these trials, there are some inclusion and exclusion criteria, and sometimes, especially for parents who are having access to all that, those are rigid limits, and that precisely to have a possible success in that therapeutical approach. When we say between 8 and 16, 4 and 16, but within this age groups, there are cardiac criteria, respiratory criteria, motor criteria that must always be taken into account. I just wish to repeat that because sometimes when we speak about clinical trials, having inclusion and exclusion criteria must always be remembered. Pat.
Of a gene therapy and developing a microdystrophin gene therapy, I think as was mentioned, iterative design is always what we need to focus on. And from our perspective, safety is always going to be paramount, especially with a first-in-human study. And so as we start younger, we always will focus on outcomes like cardiac function, making sure that our drug is also getting to the heart, getting to the important muscles, so that as we then expand from the younger age, we're able to hopefully then grow to older and older from there. But it's something that we want to make sure that we're exploring completely, and from the beginning, always having that as a criteria in mind.
Sì, e poi penso che anche il fatto dei pali.
Well, and speaking about endpoints, because you must be ready to do something. You must have sound results so that you can submit them to regulatory bodies in a way that is quite sound, quite safe. Is there any other question? Is there a trial for exon 45, 47, and 50, 62? Because reading on the net, you tend to concentrate on the part of the lesion that concerns the majority of patients, but in these small percentages of boys that have this mutation, I don't find anything on the net. And since I've here a panel of experts, I hope I can get an answer. 45-47, exon 45-47, and 50-62. Is there anyone who can answer the question? Is there anything going on for this? For duplications, we don't have a lot. There is a Klein-Flanagan study for the duplication of exon 2 that has a special mechanism. So if you can eliminate this duplication, so if you eliminate the first two exons, dystrophin can be produced because it sort of starts being produced, the protein starts being produced in exons 5 and 6. In the less frequent forms, if we find strategies, if we find molecules that can work for the most frequent forms, I think it will be very simple to apply that on the others. It's not a huge obstacle. The first strategies go on the most frequent forms because it is easier to find the patients and so understand rapidly if the strategy has an effect. If I have a fabulous strategy, but there are very few patients and I am unable to demonstrate anything, that would be useless. So when the first strategies work, it won't be a problem also to face others.
Allora, abbiamo tantissime domande che sono arrivate su.
Many questions for us, but not much time. So anyway, one is for a wave about exon 53 skipping. Will this study reach Italy too?
Yeah, that's a very relevant question because I'm here today. It's a good one. So basically, the current study design, the current Forward 53 study is operational in the UK and yet another undisclosed country or countries. So once we have enough data to confirm that actually the concept is proven, that we can express sufficient dystrophin and proceed with the program, yes, our intention is to expand into other countries, and hopefully that will include Italy.
Very well.
Another question, well, regarding the data that were showed by Dr. Previtali. Well, apparently they show a dystrophin production that seems to be very high in a given patient, intermediate in another patient, and then much lower in yet another patient. So, I mean, is there a reason behind that degree of variability, although data are generally positive in any case? So for bio.
Sorry. I could answer that question if you'd like. So basically, the microdystrophin expression that is checked for is with a process called Western blot, and it is from muscles that are sampled. And as you know, or may not know, in muscular dystrophy, Duchenne muscular dystrophy, the changes within the different parts of the muscle are not often homogeneous or uniform. So it can sometimes be reflection of what part of the muscle you are biopsying, because the amount of microdystrophin expression that you are trying to extract is coming from that single muscle that's being biopsied. And you can't ever biopsy the same muscle twice because that tissue is gone once you biopsy it. So that could be part of the problem. The other thing is that as children get older, there's a lot of fibrofatty replacement of the tissue. And when you're trying to extract the microdystrophin, there's not microdystrophin expression in the fibrofatty tissue that you can extract from, and sometimes that will also alter the results. So, but it's not set in stone that, you know, higher levels are seen in younger kids and lower levels are seen in older kids. It can often be sporadic, and this is often thought to be related to the heterogeneity of the muscle tissue's dystrophin expression.
Grazie Naz. Tempo per un'ultimissima.
One more question. Many questions regarding boys with the duplications of exons are not included in the current studies. So for those who are now involved in gene therapy studies for mutations, further exon 18, the question is the following. Are you working at finding solutions for overcoming such a limit so that these studies can also regard those who have initial, problems?
Reply very quickly.
Before exon 18.
I think the question is basically in the exclusion criteria right now, we are being conservative in understanding the pieces of the microdystrophin that are in our constructs, if there is a potential for that to then create an immune response based on a patient's unique mutation. It's a process that we have now been working extensively across companies to really be able to understand that link between specific mutations and the potential for immune response. We are working in a pre-competitive space with a collaboration led by Francesco Montoni and Karsten Bonneman to look at patient-level data and really want to refine those criteria. So from our perspective, as we start with our SGT-003 program, we are conservative. Our mutation exclusion criteria are exons 1 to 11, but specifically deletion mutations within that region, and then 42 to 45 deletion mutations as well. So we are including duplication mutations. If someone were to have a mutation, that's a duplication within those regions. But this is a process that as more data come in and we as sponsors are able to communicate, we hope to, again, refine those criteria to what may be the most potential for immunogenicity.
Grazie, direi che non abbiamo ulteriori.
Thank you very much. I think we've run out of time. Of course, if you are willing to answer these questions, you may want to receive these questions via email, and maybe you will answer them in the same way. But thank you very much in the meantime for your cooperation and for being so patient in attending this conference, especially from abroad. Thank you very much.
Sono molto felice.
And now I am very happy. Oh, sorry, there's an announcement. Please do not use musical instruments during the presentations because interpreters have a problem in translating. So let's give a big hand to our interpreters, who, of course, thank the audience. Thank you very much. But musical instruments may intrude, so to speak. Okay, it is indeed an honor for us to introduce you to our next speaker, David Allison from the Treat-NMD Service Limited. And you might already know about this organization, which includes academicians working in the neuromuscular field. We've been working with them for quite many years now for several projects, especially those regarding patient registries. So we are very happy to be included in this project through David Allison in particular. So we are general coordinators, whereas they are scientific coordinators, but we do work together. Now, David, you have the floor.
Thank you.
Okay, good morning, buongiorno. It's a pleasure to be here today again to talk to you about Project PaLaDIn on behalf of Treat-NMD, friends at Parent Project Italy, and all the other partners involved in Project PaLaDIn, many of whom are here today. Project PaLaDIn is a really transformational project, we believe, and our proposition to the European Commission was that if you really harness the energy of patients and their families and those impacted by neuromuscular disease, and you really harness the data, we can significantly improve decision-making across the whole drug development pipeline and subsequently. And that isn't just important for neuromuscular disease, it could be scalable to rare disease and in fact many aspects of healthcare generally. And the European Commission found that really interesting and a very compelling proposition. So they've funded this 4-year project through Horizon Europe to the tune of 21.4 million euros to really do something very, very exciting that I'm going to talk to you a little bit about. So the partners that you can see there, Treat-NMD is the scientific coordinator, but as I'm sure Ilaria mentioned in her introduction, this project's been led by Duchenne Parent Project Italy because patients are absolutely at the centre of this project, and it's all about enhancing the patient voice in decision-making in neuromuscular disease. And therefore it's right that it's actually being run by Parent Project Italy with the support of Treat-NMD and the various other organisations. You can see there that Duchenne is recognised, Becker is recognised, FSHD, myotonic dystrophy. What this project is about is recognising there are some really excellent things happening in different advocacy areas and different disease areas, but what could we do if we scale that up and get the synergies of taking the good things that all of these organisations are doing and do it at scale and accelerate it over the next 4 years. And each member brings different things to the consortium, of course. You know, here we are today and we're talking about patient education and patient data collection with Parent Project Italy and so on. As I go through, you know, Treat-NMD brings registry networks and data collection infrastructure and again support with regards to education. You can read faster than I can talk. Although being Scottish, I'm used to having to slow down so that English people can understand me. And I'm hoping the pace of this presentation is such that it's okay for the translators. So you have a range of expertise coming together in the various partners, and each of these partners is leading a work package within the overall project. So what is the project? Well, at the moment, you'll be familiar that we gather data in registries, and we're always encouraging parents, patients to contribute data to the registries, because these registries are used by all sorts of stakeholders, industry, payers, regulators, clinicians, to make decisions. But really, you can see from this slide that the regulators, the payers, industry tend to be the major users of registries. And of course, the clinicians are gathering data and inputting data in order to make clinical decisions and support the care of the patient. But what we were really saying is, if we could really gather patient data, if patients could understand and families could understand and see and feel that their data was being used, the information that they felt was important was actually being used in really impactful ways, then what would that mean for regulators, for payers, for industry? And of course, what we want to do all the time is to be able to answer the what's in it for me question. If you're going to want me to put data in as a patient, as a family, then I want to be able to feel that it's making a difference. What am I going to get out of it? And therefore patients being able to see an improved care and a quality of life improvement as a result. And clinicians getting some benefit from gathering that data as well. So our proposition was that if we could enthuse parents and patients to really contribute all sorts of information that they felt was important, we could do really significant things. And that's why at the heart of it, we're creating this project, we're creating what we're calling the Interactium. And the Interactium will actually make these things happen. So what will the Interactium do? In addition to gathering the information that we currently have and a lot of the clinical information that's put in for decision making, what we're really looking at is all information that people feel, that patients and their families feel would be valuable. So wearable information around health, and such as heart rate, sleeping, etc. Wearables in terms of the activity. In terms of steps carried out, information around food, around vitamins, around supplements, information from diaries and journals. IoT stands for the Internet of Things. There is so much information available now that we can utilize technology to be able to make better decisions and faster decisions. But other sources of information might also be important that's never been considered before because we've never been able to join information together in a compelling way. So do people feel different at different times of the year? Are pain thresholds different at different times of the year, depending on the weather? What other things could actually have a real impact that we need to understand by gathering the data and getting insights that we've never, ever had before? And of course, anything else that the patient believes is important. We often see that decisions are made by regulators that patients find frustrating. Well, why is that? Because they must have information and insight that feels different. So again, what other information can we get from patients that we can feed into the Interactium? And of course, what are we looking to achieve? Well, being able to track your Duchenne or your Becker experience in one place, being able to access all relevant information and educational material, be able to see real-time data on your condition, be able to compare what your own personal journey is against what the information says best practice looks like, and be able to say, in my country, because we want to deal with this globally. In my country, am I getting the best possible care? And how does the care in my country compare with other countries? And are there opportunities to do things different along the pathway, whether that's diagnosis or whether that's care? And then information about clinical trials, being able to connect people. Industry often finds, you've heard earlier about inevitably there are conditions about who can take part in what clinical trials, and industry find it very difficult to be able to identify patients and engage proactively with patients to support those clinical trials, but likewise patients and families find it difficult to know what they might be eligible for and how to connect with clinical trials. So again, being able to have a single one-stop shop where this can be connected together would be really powerful. And also, what we really want to do is to make sure that we can support policy change. If we're gathering data and gaining insights that we've never had before, how can we use that? And that's why there are so many patient advocacy groups that are part of the PaLaDIn partnership, to make sure that we understand and how can we use this data to make a real difference. Support the development of patient-reported outcomes. We'll have the opportunity using technology to be able to do things in a much more powerful way. But at the end of the day, this is about giving patients a louder voice, not only in drug development, but in actual fact about the decision-making around healthcare that affects the patient and the families. So we really think that neuromuscular disease has the opportunity and the PaLaDIn Project to do something genuinely transformational, looking forward rather than in the rear-view mirror, to think about how we can fundamentally change decision-making in the world of neuromuscular disease that will have a lot of relevance to the wider rare disease and, in fact, healthcare more generally. And we're absolutely delighted and excited about moving forward. The project started on the 1st of January. We're having our kick-off meeting here in Rome on the 11th and 12th of March with everybody coming together. And we really are very excited about doing something that we feel could be genuinely transformational. Huge thank you. Thank you for allowing me the opportunity just to raise the profile with you. We'd love for people to get involved. Please visit the PaLaDIn website. There's an area of the website where you can register your interest, and we'd love to get as many people engaged and involved as possible over the next 4 years to make a real difference. Thanks very much for your time.
Grazie tantissimo David, sei stato chiarissimo.
Thank you. Thank you. You've been very adamant, clear. The project is a very ambitious one, and we are really very glad to be a part of it. Just stay with us for an extra 15 minutes, and that is linked to the poster session. The poster session will be held from 1 to 2 at floor -1. So young researchers were asked to participate in a sort of prize awarding event, and you will be the persons who vote. And the idea is really of making people understand. So these are videos. There are 7 videos, 1-minute videos. Each of them has a number. So look at them carefully to the very end, and you choose the one that is easier to understand. And at the end, you can vote with a QR code that you will find on your tables, and the winner will receive his award this evening. And this year, it will be here in this room. So we can start with the videos.
Sono Chiara Fagionato, sono una biologa e ricercatrice in genetica medica e
I work in the area of pre-implant diagnosis. The PGT means the couples to conceive healthy children, but how can we do that? I'm very sorry, but it is a recorded message at incredible speed. It's impossible to translate simultaneously.
Non appena abbiamo una diagnosi, insieme ai futuri genitori identifichiamo l'embrione sano da trasferire nell'utero materno per iniziare una gravidanza. Grazie al progetto PNRR di cui faccio parte presso l'unità operativa di Padova, il PGT potrà essere offerto alle famiglie come prestazione pubblica nella regione di provenienza. Se volete saperne di più, potete consultare il poster esposto durante la conferenza e il nostro sito web www.embryo-gen.it. In questi 2 giorni io sarò disponibile per le vostre domande.
Mi presento.
Well, I am DMD. Would you like to play with me? The most expert mice and the apprentices understood there was a trick behind that. So one of DMX mice went towards the castle of the magic supreme mouse. Supreme Mouse, how can we fight DMD? In the wood you'll find a brook, and the special water is rich in GMV 9844. It is a magic potion, and so the mouse went to the wood, but DMD was ready to attack it. But after drinking the water of the brook, something surprising happened, and GMV 2894 had increased the strength of his hind paws, control of inflammation, reduction of muscle fibrosis. DMD was scared, so then the D2 MDX informed his friends, and they couldn't believe their eyes. Well, BL10 MDX, but what happened to you? Dear friends, you must absolutely drink the water of that brook, the one that is close to the castle of the Supreme Mouse. So all these mice went towards the brook to drink the water. It is a fairy tale, but what has happened in research lab, and now have a look at my poster to discover what happened in research labs.
Oggi è il giorno delle dimissioni. Questa è la macchina della tosse su cui è stato fatto.
This is the cough machine, and you had the training. Here you see all the indications, and here you see a code enabling you to visualize video tutorials on how to use the cough machine. If you have this code on the Mars phone, you can, well, it will tell you how to use the cough machine, and it is present also on the cough machine. The QR code is present also on the cough machine. So you scan this code, and as you see, the video is a video tutorial that is starting now. Okay, is that clear? Thank you.
In questo lavoro abbiamo studiato la prevalenza.
We studied the prevalence of obsessive-compulsive disorder in DMD patients and correlation with their psychopathological traits. We used a study method with standardized criteria. We assessed 77 patients with DMD, average age 12, and the results were quite significant. More than had obsessive-compulsive traits, and they were classified in subclinical, mild, and moderate. But we didn't stop there. There was an interview for DSM-5 for mental disorders, showed a correlation between obsessive-compulsive disorder and verbal behavior. The traits were more frequent in patients, in some patients with UC, and what does that mean? Well, the traits of the obsessive-compulsive disorder with DMD, they are linked with cognitive and psychopathological traits that may lead signs of emotional and behavioral aspects. So we need comprehensive assessment of the patients for targeted interventions. So it is very important to adopt a holistic approach vis-à-vis this complex genetic disease. Well, today I'll tell you the story of two special mice, BL10MDX and D2MDX. They had in common a defect in the dystrophin protein, so they were smaller and less strong than the other mice. And one day they heard the scientists were looking for someone who could help them study DMD and try to find a treatment. They both immediately thought it might be a great opportunity to help out, but the researcher position was only one. A lot of participants came to the announcement, but the researchers immediately realized how special the mice were. So for 42 weeks, they underwent a number of tests until they reached the most difficult test, the DNA test assessed by the dreaded Mr. PCR. Mr. PCR asked the mice to write an essay in which they wrote down all their characteristics and reason why they should be chosen. And after that, Mr. PCR made a number of copies. The PCR made numerous copies of the two essays so that his helpers could also read them, compare them, and work out which of the mice had the patience and dedication to become a researcher. Which mouse will have succeeded in convincing Mr. PCR? Well, we'll tell you that at our next story.
Salve a tutti.
I'm a researcher of the Santa Lucia Foundation in Rome. In our lab, we deal with DMD and the pharmacological treatment with G-Vinostat. Over the last few years, we concentrated on small vesicles that are released by a cell population that is called as FAPS. And more specifically, we observed that the pharmacological treatment with inhibitors modulates the content of these vesicles, and so they become transported of a pro-regenerative message in order to improve the general conditions of the muscle. In our poster, we demonstrate that the pharmacological treatment improves the expression of the protein in the vesicles, and once transferred in the stem cells of the muscle, can regulate their asymmetrical splitting and their activity in repairing the dystrophic muscle.
Ecco, questi erano I video.
So these were the videos, and you can frame the QR code. Please vote. They are already voting because it had been sent beforehand, so I can see that the voting is working. We can put it on the monitor. We have already shared it before, but now we'll show it again. And two announcements. Please, each of you, will you carry one of the musical instruments, one or more than one, so that Stefano can collect all the musical instruments, and then we reconvene after the coffee break. At 11:30, please be on time. And in the plenary session, we have a round table on social activities. And whereas in the Pergamo room, we have a parallel session completely devoted to Becker disease. Thank you. Enjoy your coffee.
Allora, se puoi, prova il 58 un attimo.
Prova.
Ancora.
Ehi.
Ok, perfetto. Allora, aspetta. Sì, E. K. Un attimo se per caso è vero che sono libero allo streaming. Sono in streaming?
Perché forse mi passa dalle lingue.
Ragazzi, quando siete pronti proviamo, eh? Poi dopo vi sistemate meglio. Facciamo un attimo la prova tecnica tra di noi, altrimenti non ci basta tempo.
questa la giacchetta, tutta, poi mi metto la maglia, mi fate buttare.
Cominciamo a rientrare per riprendere i lavori della conferenza. Grazie.
Addirittura, vai tu che sei.
Potete iniziare a accomodarvi, a chiamare i vostri amici fuori se sono rimasti fuori. Stiamo per ricominciare. Abbiamo bisogno di restare nei tempi per poter fare tutto al meglio e fare in modo che, essendo contenti, fuori si sente il microfono? Se vado in giro fuori, no, Per favore, stiamo per ricominciare. Vi invitiamo a riaccomodarvi perché stiamo per ricominciare. Monica e Mario. Ora li chiamo per nome. Stiamo per ricominciare, siete tutti invitati a rientrare, altrimenti vi perdete l'inizio di una bellissima tavola rotonda. Vilma e Mario. Vilma e Mario, stiamo per ricominciare. Portate tutte le persone con voi. Questo è quello che sta succedendo.
E poi io annuncio un amico.
No, Giuseppe, su ce n'è un altro.
Annuncio un fatto di fare sempre per sistemare. Ok, che vuoi incontrato con una faccia vuota uguale?
Ho girato il microfono. Ho riconsegnato il microfono.
Sì, però sempre
Però
acceso.
allora se lo voglio
Purtroppo.
spegnere devo fare così.
Questo è il 3?
Ma non lo
E quello è il 4? C'hai tu il 4?
Di accomodare.
G4. No, non è così? 4. Viola e marrone. Viola e marrone.
Cosa?
Ah, questa roba, aspetta, c'è qualche collega. Giuseppe, me la tieni la mia borsa? Grazie.
Prego.
Sì, conviene fare non mi serve, lascia.
Apri la porta. Sì, dove siamo noi, Emma? Qual è il tavolo sta? Dove possiamo? Qui io ci ho provato, mi sono volato, ma purtroppo.
Mari, l'altro microfono invece lì è acceso? Non è acceso. Ah, una lucina rossa. Non vuol dire. Ah, ok.
Non è
Troppo aggressive. Ok. Io intanto vado,
Ma scusa,
No. Quando io do il via alla salita dei relatori, tu inizi a... invito i relatori a salire. No, intanto loro si accomodano. Sara durante le sedute e intanto c'è prima l'annuncio della tante, loro si sistemano. Facciamo un momento motivazionale in mezzo a me.
Sì? Facciamo, le potete dire le parolacce, sì. Certo, le potete dire una parolaccina.
Una parolaccia che si dice prima di un evento teatrale.
Vogliamo fare guarda.
Quella si può dire, magenta. Pronti?
Pronti? Qui, Tony, queste tre. 1, 2, 3. Merda, merda, merda.
Lui che fa teatro lo sa.
Eccoci, stiamo per ricominciare i lavori. Chiediamo a tutti di sedersi per ascoltare gli interventi di questa tavola rotonda. Allora, io sono Marica Pugliese, sono una delle psicologhe del Centro Ascolto Nazionale e condurrò questa tavola insieme ad una collega. Invito quindi tutti i relatori a prendere posto sul palco. E nel frattempo abbiamo un messaggio molto importante da darvi.
We have a very important message to convey. It has to do the Cadanchio campaign. We'd like upon Dr. D'Amico who bear her witness with regard to the work that we do together and the experience in the Centro Ascolto Duchenne, which is a self-help group.
Buongiorno a tutti, io sono Dalle D'Amico,
Good morning. I am a neuropediatrician at the Bambino Gesù Hospital. I'm Dr. D'Amico. I was involved in this campaign. Well, they involved me, and I'm really happy to be involved because I'd like to bring the testimony of our hospital. Some families here have shared this experience because when they came to the hospital, they were received by us. They were welcomed by the social workers, the psychologists at the counseling center, and they started this journey. I don't remember when, maybe back in 2015, but anyway, about a decade ago, we decided to open up a special counseling facility inside the hospital. So when we had children who had dystrophy, muscular dystrophy in the hospital, sometimes a psychologist and the social worker would be present at the first diagnosis and then subsequently. This definitely enriched my way of communicating diagnosis and taking care of children. And I think it was really important and useful for the families too to meet with the association early on. It's been reported in scientific studies that at the time of communication of diagnosis is significant, and I think you all have basically experienced that. Acceptance takes a long time, but the time in which the diagnosis is revealed, well, it's part of the process of acceptance, and it is of paramount importance. They wanted to involve me because they heard me speak a few years back. What I said is that we study medicine, and for 6 years we take a lot of exams. And when I was awarded a degree, there is no class concerning a communication of diagnosis to patients. That was ignored. Instead, it's really, really important because I learned from psychologists at the Parent Project program. I learned a lot of things. Right now, they're not with us at the hospital, but thanks to their input, we trained a psychologist who spoke yesterday, and she'll speak again. With them, we created a network. So every new young patient who is welcomed, of course, with the consensus of the family, is put in contact with the counseling center, and families that know us can bear witness to the fact that whenever there's a problem of a psychological or social nature affecting the whole family, we try to establish a contact between them and the enlarged community or family, so the school, not just the hospital, but friends and peers We do all this in order to try to improve the long journey that we're all going to be undertaking together. So I'm really happy to be able to promote this campaign, and I hope you will contribute to it. Thank you.
Ecco, non potevamo iniziare meglio, anche questa tavola rotonda che, come avete letto, ha...
So we're ready to begin our round table, which is going to focus on social interaction. This is very important to us as an association because often families raise this issue. They tell us that often the road is not so linear. There are times in which their children are welcome, but others in which they're discriminated against and excluded. And therefore, we try to work very hard in the area of social relations, and that's why we organized this round table and invited several speakers who are going to bring to us their experience. We believe that every point of view is important to build good practices. That's the ultimate goal. So we have different testimonials. Of course, I had the cooperation of Sara Pillai, a psychologist of the Consulting Center for Sardinia. And then we have illustrious guests, some of whom you know already. First of all, we have Professor Alessio Cinotti, who teaches special education at the Bicocca University in Milan. Then we have Antonio Vigoroso, who is Giuseppe's father. Then Marco Mazzariola, who I'm sure you've seen because he's very well known here at the association, and Daniele Amanti, another well-known person in the association, and then the extraordinary participation of Veronica. Lulu Rimmel is her stage name, who will share their experience with us. Let's begin with the needs manifested at the counseling center. So I give the floor to Sara. Thank you for your question. Good morning, everyone. This question is important because I can explain in greater detail what it is that we do at our center. When it comes to social interaction, one of the first areas where we take action is schools. In schools, we do several things. One is to call on working groups, operational working groups, and then we provide information and formation or training to faculty, to teachers, so that we can explain to them what Duchenne and Becker's muscular dystrophy is all about. Sometimes we organize meetings with the whole class involving students, and as you can imagine, there's a playful component to these meetings. But it's not just schools where we go, because that's not the only place where our children can develop social skills. Sometimes we help families to find places in which these skills can be developed in addition to school. And we try to hone in on the different emotions that revolve around social skills. Wherever there are no good practices, it's important to work on parental trust. Sometimes parents have a difficulty in letting go of their children and making them independent, but we also work on the kids themselves to help them find which resources they want to focus on in the different contexts. And sometimes we need to deal with different emotions too, like anger, frustration, and disappointment when these social relations don't happen in such a positive way. As you can see, I mentioned some of these emotions only, but I'm sure that each one of you felt others. And I'm also sure that you will come into contact with those emotions as you hear the contributions of today. And that's why, without further ado, I'd like to give the floor to our expert today, Professor Cinotti. First of all, welcome. And she's going to provide us with a more theoretical picture of this. Let me ask you a question, if I may. The idea is to promote inclusion. when we use terms like welcoming, hosting, integrating, and including, do you think that it's just semantics, or do you think that there's something more? Thank you. Thank you, Sara. And thank you to Marika. Good morning, everyone. I'm very happy to be here with us. I also would like to thank those who are going to be making contributions. I thank them ahead of time. I did get a little bit of a preview of these contributions, and I found them to be quite captivating. And they really prompted some reflections in me, which I would like to briefly share with you. Thank you for that question. What can I say? Academically, I'm responsible for teaching and training. So what I do is I train future educators and support teachers. So in the school setting, and in particular, support teachers in primary school and in kindergarten. And these are settings known to you because I was able to read about them in your contributions. What I think is really crucial in training and education, and we're talking about the education of future professionals who are going to be meeting other parents, other families, and other kids. Anyway, I was saying that a very special area is that of words, for me anyway. Here you say everything counts. That seems to be the slogan here of the theme. And to that, I would add every word counts, because all the words that we use are words that are not neutral, but they convey messages. And somehow, they also tell us something about the culture of a given society, if you think in macro terms, or in micro terms, they tell us about the culture of a school, a given context, a district, a neighborhood, areas that we belong in and which we inhabit on a daily basis. So words tell us something about the different cultures that revolve around certain themes. So specific needs, inclusion, social skills, but they also tell us something about what we think and our mental and social representations of these issues. Let me give you an example. If I'm an educator working at an educational center that sees disabled adults, and I turn to an adult and say to him, let's go eat un gelatino, which in Italian means a little ice cream. That says something about that person and the culture, because the word gelatino, little ice cream, is something that you would tell a child, right? Thank you for suggesting that in the audience. Yes, you wouldn't ever say the word gelatino, little ice cream, to an adult. You would use that word with a child. So we mustn't overlook chronological age. We must be respected and protected, and also through the use of words. So my point here is that words are important, and words speak to us about the social, historical, and political journey behind us. And it is a journey that in Italy started in the 70s, when the first children with disabilities were integrated in ordinary schools, in neighborhood schools. And by that, I mean schools near home. So parents were able to choose a school near their home that could be reached on foot or with public transportation, rather than a school that might have been very far away. and that would have implied having to travel a certain distance to reach it, which obviously has an impact on our daily life. So you were asking me, is this just semantics? My answer is no, it's not, because words tell us a lot of things. They convey certain cultures, and inclusion certainly has to do with some of the words that we heard, like acceptance, welcoming, integration, inclusion, and social skills. All these words are part of inclusion, of the concept of inclusion. But not only that, as an educator, I believe that inclusion requires a certain necessary conditions. The first of which is to blur the dividing line between people without disability from those with disabilities. So we need to do away with that dividing line between what is so-called normal and what is different from normal. Inclusion as a concept basically says, hey, wait a minute, we're all different, regardless of whether or not we have a disability. We're all different, and if we look around, we realize that that's the case. Some of us have long hair, some have short hair, some come from a city, others come from a different city or a different town. Some of us take a little longer to learn, others learn more quickly. Some of us love to walk in our leisure time, whereas others like to sit on the couch and watch a movie. All this basically says that we are different. And above and beyond the way in which society labels us. And the idea of inclusion is a way to overcome this boundary that tends to divide people into groups. We have to remember that differences are part of human existence, and there are infinite differences. I think this is crucial. And the second concept that speaks to inclusion, I think, is the idea that we should prioritize any action or context in any action that we do. Let me give you an example. It's a very simple one, but I think it's significant. It's meaningful. And it's just an example to try to understand what I mean when I say that we should operate or try to change or work with context as a priority. If I am looking at a building that has architectural barriers and I have a motor disability and I'm not able to go to the second floor in that building, it's not my responsibility to get there. It's not because I have certain traits that it's my problem, but this is a collective responsibility. I'm sorry, this is rather trivial, but I just want to exemplify my idea. I think it's a collective responsibility which calls into the picture those who designed the building. Those who designed the building didn't think that it should be used by all, because the building suits some people, but not everybody. So this means that we need to shift our focus from the individual to society towards collective joint responsibilities that call upon us all, each one of us with their own role and their own area of competence. If that building or that architectural barrier is either replaced, if this barrier is a staircase, if next to that staircase a ramp is built, the ramp will become a space that enables everybody, not just a person with a motor disability, to be able to independently choose to use it rather than the stairs to be able to access that building. This is really a cultural effort because it means shifting our focus from the individual with the infinite characteristics and traits to contexts that need to be contexts designed for a population which by definition is always going to be very diverse, composed of people who are different. Building a ramp. Actually, let me ask you, who do you think the ramp is mainly used by? Yes, please. What's your answer? And what is your name? What is your name, please? Alice. Alice says a mom with a pram. Right. Benedetto adds a dad too, not just a mom. Somebody else says that the ramp could be used by an elderly person. Anybody else? Benedetto, what is your answer? Yes, a visually impaired person. Well, if I'm lazy and I don't want to go up the stairs, I could use it. Okay, Riccardo. Or somebody who's wearing skates. Somebody who likes to wear roller skates. Okay, well, thank you for your answers. What I'm saying here is that the transformation of context is one that aims at building a society, a building, a neighborhood that's inclusive for everyone, not only for some individuals. And with this example, I think we understood that readily. You know, your answer said an elderly person, somebody wearing roller skates, someone who has a problem with their knee. So this means that inclusion tries to increase ordinary responses like ramps and make them available to everybody so that they can benefit everyone. This is really a cultural shift because it's like changing your eyeglasses and changing your focus and the perspective from which we observe different phenomena and everything that is around us. There is a question here, I think. Can we hear it?
Non ti sentono.
Dicevo che è solo...
I was saying that only Italy is this way because if you go to Northern Europe, no one has a problem if they're in a wheelchair. If you go to the US, they can go all the way up to the 8th floor. In my city, there's only one school that has ramps and not staircases. It's Italy that needs to change, our country. Yes, Anna. I think you're reminding us of a fundamental passage here, which is that, of course, inclusion is a collective challenge. It doesn't concern the individual or an individual family or an individual parent, mother or father, but it is a question, a matter that involves the entire community, starting with designers and decision makers, lawmakers, engineers, doctors, everybody, all the professionals that would be involved. Because disability is not something that affects certain families only, but it's cross-cutting to our society and our culture, so that every one of us, regardless of the way that we were born, we may find ourselves in a situation in which we may have to go up ramps. Why ramps? Well, because it's an example that people understand readily, but that also makes us realize that inclusion is not only about architectural barriers, but also many other dimensions. The dimension of learning at school, that of socializing, and so on and so forth. But the message I want to leave you with is that as a cultural and collective challenge, we should try to modify our vantage point, not as individuals, but as a community, as a society. I'm going to conclude, Sara. Or do you want me to end here? Okay. One last element that I'd like to raise or bring to your attention is the fact that inclusion can be learned. Inclusion is a journey. The theoreticians of inclusion tell us that it's a perspective, a prospect, it's a beacon, it's a direction we should strive to move towards every single day with actions and choices at every single level, but we never actually reach it. But inclusion is about learning to build more inclusive contexts, whether they be at school or other contexts. We need, and here I go back to what Marika said at the beginning, we need different vantage points. And inclusion is about this. It's about establishing a dialogue between different points of view and making sure that everyone can bring their own experience and knowledge to the table. And each one of us has knowledge that has the same value and dignity as that of others. Our knowledge is complementary, but it should be connected because lessons learned must be made available to all beyond the family. Only this way can we bring about small but significant changes towards inclusion.
Grazie moltissimo, interessantissima questa riflessione.
Thank you very much. That was very interesting. Thanks for what you said about words, and thanks for involving the audience. They all seem to be very interested in participating in this round table, so thank you for that. And now it's time for us to listen to some testimonials, so to speak. We're going to start with our dad. His name is Tony. And actually, I'd like to ask you to introduce yourself to us all. Maybe you'll tell us something about your family and your experience in these fields. Good morning, everybody. Thank you, Sara. Well, I'm actually quite nervous in taking the floor, but I'm also excited to do so, to talk to you about my experience as a parent. Talking about social interaction and inclusion, I may indeed have something to say. My name is Antonio Vigoroso. I'm the dad of Giuseppe, who is 8 years old. And in 2017, on the occasion of a blood testing, we realized that CPK was particularly high. That basically said that Giuseppe was a DMD patient. We are from Reggio Calabria, southern Italy, and we realized that unfortunately we could not have access to any help in the area. Therefore, we decided to be strong enough and to find even more strength to move forward, because of course Giuseppe is not only his disease, so we really wanted him to grow vigorous, as his name tells, by the way. So we are quite a large family, quite a big family, and social interaction came immediately after his birth. Basically, he went to the kindergarten when he was only 1 year old. Then his sister was born, and that was another chance for him to get in touch with many more people. And then primary school began. And there we realized what Giuseppe was like. Well, he's a very generous boy, a very sensitive one, but he's also a fighter. And we realized that only on the occasion of the different medical referrals that he had to undergo, he was highly cooperative. We felt like he thought he would be doing the right thing to get better. He is quite a sociable boy, and he has several friends at school. He's sort of, the boy of his, the mascot, if you wish, of his class. But of course, some problems also arose. Let me give you some examples. When he was doing his homework and he made some mistakes, he felt like that was a failure. Such a big failure that he felt frustrated and even felt like he should leave the classroom because he just couldn't take it, so to speak. He sometimes asked for help, but he wrote that in his diary and did not say that to anybody just because maybe a classmate was not very nice in answering to some of his questions. So, I mean, we felt like there was room for improvement, so to speak, and we were supposed to work on his self-esteem. Well, as parents, we have always found the right balance in connecting the different activities Giuseppe is engaged in. We've always tried to make him feel free to engage in any activities he might want to engage in. Sometimes, of course, experiences may not be good, but we felt like he should take them on too. And so what can I say? He's a boy who helps us a lot. We are very lucky parents because he makes it so much easier for us to help him as parents. And we're also lucky because we are engaged in constant relationships with people like his physical therapist, his specific teacher, and Parent Project Association that is really on our side on a daily basis. Actually, Giuseppe turned 8 yesterday, so celebrating his 8th birthday here was perfectly okay for us because we feel like you're a family for us. I have a question. For Professor Cinotti. Actually, sports account for an issue, if you wish, because our boy has asked us to start fencing lessons, and we actually tried to make his dream come true. But then we talked this over with his physical therapist, who told us that was not exactly a kind of a sport that he could truly benefit from. And his instructor was way too cautious. You know, he feared he might get hurt. But now he's a sort of an obsession for him because he knows that he can't practice fencing anymore, and that is a problem for him. Thank you. Sara, you have the floor. Thank you, Tony. Thank you very much for taking the floor. Thanks for being so emotional in talking to us. Well, I understand you have already talked about this problem with your physical therapist, possibly even Cristina Bella from our association. Actually, within our counseling center, we have actually Cristina Bella, whom you haven't met yet. Well, she can actually give you some indications about the best possible movements for your boy. And I also think that we need to promote our boys' needs and wishes, and sometimes we'll have to cope with the frustration that comes out of some bad experiences. Marika, would you like to say something else? Well, actually, before the professor's answer, I'd like to just say that this is also a cultural issue because, motor activities at schools are just given activities. So some sports are simply not practiced, although they may be actually accessible to other students. Well, actually, that is something I was precisely going to say, something cultural, so to speak, accessibility, of course, in a broader sense. So a cultural kind of an accessibility, whereby one may think that sports should really be made accessible to all. Now, I'm not sure I'm actually answering the question the dad asked about his boy, Giuseppe, whom I might very much like to meet, by the way. So my answer may be too partial right now, precisely because I don't know him. But thank you very much for your question. I do believe it goes hand in hand with what we are aiming at with this round table. We want to talk about social interaction within, of course, schools, but also within contexts in general. I mean, museums, schools, of course, but I mean, public spaces or holiday places. So we probably need to make a cultural effort whereby we can start to imagine such wide-ranging accessibility to sports. So, as Marika said, we should try and even consider schools' proposals from this perspective. I mean, these proposals may not always be accessible to disabled children, but also to some, specific children more in general. I mean, there may be children who do not like that particular sport, who don't feel like that is their actual aptitude. So what do we mean by an actual quality of life? Something that highlights the meaning of leisure time. Our daily life does include many things, and leisure time is one of them. Teresa, would you like to tell us what leisure time is about? Well, leisure time is about interacting. Carol, our grandson, well, he's really our life, you know, both for us grandparents and for his parents. We would so much like that he might actually be part of, take an active part in a sports activity. We come from Apulia, in southern Italy, where we don't get much, to that respect. Well, leisure time is about leisure, is about pleasure. And by the way, what do we actually like to do? That may be a difficult question, So leisure time is a time that no third parties can choose for you, but it's a kind of time that precisely starts from our own needs and wishes. Well, we often want our grandson, for example, to do swimming, but he's not interested. So, should we keep insisting or not? Well, I'm not sure, but your grandson is very right in telling you that he doesn't like swimming. I mean, it's his own right. We all have the right to say no, thank you. And Carol is very good. Sometimes even in our family, people keep saying swimming is great, but she says, I don't like the sea. I mean, I don't like swimming in the sea. I just like watching the sea, which is a very good indication, Marco was saying before that, he likes asking questions, but he's also a good listener. And your grandson has said something very important. I don't like swimming in the sea, but I like watching the sea.
Grazie mille. Allora, adesso quindi non ci dare i nostri ragazzi.
So let's now give the floor to our young guests. I start with Daniele. I'd like to ask you the same question. What were your experiences of relating to your peers? Were there any problems, and if so, how did you overcome them? And would you like to leave us with a message for everyone? Hello, everyone. I'm Daniele Amanti. I'm 17 years old. And I'd like to speak to you about my experiences in relating with my peers. I've always been very sociable. And it's easy for me to make friends. So my experience with other people has always been very positive. They've never really focused on my disability. They just saw me as who I was, who I am, Daniele, a kid like anybody else. The only thing is that they were a little bit curious, because someone with a disability is bound to arouse curiosity in others, but it was never, they were never critical or anything like that. So with my peers, I never had problems. What was instead a little bit difficult, or more difficult, was my relationship with teachers. For instance, at the beginning of grammar school, I often had to go to the bathroom, and it would happen that sometimes the teachers wouldn't let me go because they didn't realize that this had to do with my illness, or else there was a little bit of discrimination sometimes. One such episode happened last year. I wanted to leave school on my own, but I was told that I couldn't because of responsibility issues. I think that their intentions were good. They wanted to protect me in saying that, but it was a little bit of a discrimination against me too, because after all, I have nothing different. I'm no different to other kids.
No, volevo chiedere a Daniele perché questa storia
I'd like to ask you a question, Daniele. I know the story really well. I got very angry, Daniele. How did things work out in the end? Well, in the end, they understood that it didn't really make a lot of sense to prevent me from going. Thank you, Daniele. You're helping us to focus attention on a very important aspect, which is that even when peers are inclusive and accepting and they don't really notice the differences that we are talking about, or they might notice them but not turn them into a problem, then sometimes the response of adults is not always as good. And paradoxically, Daniele's greatest problems happen with teachers, with adults. They didn't understand his needs, those related to his disability. But not only that, last year they didn't allow him to go home on foot or in his chair, in his wheelchair with his friends. So, you know, this was really an act of discrimination. And they did not understand the need for him to be independent and going home with his friends, maybe having a sandwich somewhere on the way, and just spending his leisure time. I mean, if we remember back to our school days, the nicest part was going to school and going home with our friends. So why we couldn't understand why Daniele should be excluded or prevented from having that experience also. So thank you for sharing that. Would you like to say anything or convey a message to the community? Well, simply that when these difficulties come up, don't get discouraged. Look at other positive sides. They're really important.
Allora, siccome abbiamo
Since we really thought about how important it is to build an inclusive and accepting context, we also asked Marco to come and share his experience with us. So the questions I'd like to ask you are the same I asked Daniele. How did you experience and perceive this type of situation? Thank you, Marika. Some of you already know me. I'll introduce myself anyway. I'm Marco Mazzariol. I'm 12 years old, and I come from Treviso.
Allora, Marco.
Okay, Marco. How was socializing with your peers and with your friends? Well, my social experiences with peers were almost always without a problem. Almost always, not always. Almost always because at the beginning, in early kindergarten and grammar school, they cast me aside a little bit because they hadn't been accustomed to seeing someone as, well, a particular kid like me. This obviously didn't help because I felt a bit rejected. I felt like they were ignoring me just because I'm different. So I said to myself, that I wanted to show others how special I am. I wanted to show them that I'm not that different after all, and essentially I'm one of them, except that I can't walk. But what really matters is personality.
Grazie.
Thank you, Marco. You were saying that there were difficult experiences, and you were talking earlier about playful moments during school, right? Well, one difficult moment was when I had to give up joining a theater course because the stage was not accessible to me. There was no ramp, and so I had to give up. And this really upset me because I realized that they didn't think that even kids with special needs like me might want to participate in an acting course. I had to give up. But I didn't give up hope. I kept looking for the right acting class, and he found it. You understand how important it is for Marco, because his qualities, I think, are very clear to us all. Would you like to tell us about some positive experiences in these terms? What happened to you in recent times? Well, one positive experience was when I took another theater course, another acting course called Teatro Compagnia, which was accessible this time. I was able to go up on stage, and I was really happy because I was super patient, and I was rewarded by being able to find the right acting course for me.
Poi un'altra esperienza.
Another positive experience happened just in recent weeks. I became the municipal advisor for youth in my municipality, Carbonell. And it was thanks to my peers who supported my candidacy, but also my teachers who voted for me and elected me.
Diciamo che Marco è ancora indeciso tra l'attore.
Marco still hasn't made up his mind. He doesn't know whether he wants to be an actor or a politician, or maybe both.
Marco?
Do you have a message you want to give us? Yes. A message I want to leave you with is be yourself with your peers, and whenever there are difficulties, never give up. Never give up. Just keep going and find the strength to go ahead.
Grazie. Veronica, adesso è un duro compito.
Veronica, after Daniele and Marco, they're quite a tough act to follow, but I'll give you the microphone and I'm going to ask you to tell us about your experience. Tell us how your art contributed to all this. Hello, everyone. I'm Veronica Tulli, and my stage name is Lulu Rimmel. And today, I'm really very moved. I'm so happy to be here and to have been invited to share my experience as a disabled person. Although I don't have the Duchenne muscular dystrophy. But we do have very similar experiences when it comes to inclusion and when it comes to discrimination in general. As far as I'm concerned, I'm a little bit older. I'm not going to tell you how old I am, but they're kids. I'm not. I can tell you that I'm very happy to see how things can change even over a few years. And I completely agree with what all of you have been saying about the need to raise cultural awareness. It's very easy to add a ramp where it's needed or to do away with architectural barriers. That's easy to do. The hard part is the cultural change. I think Anna in the audience was saying this. I'm sure that there's a lot of work to do in terms of rights and culturally speaking. My experience with regard to socializing with peers in grammar school were very difficult because people were not adequately prepared. They had not been educated to accept a different person with a different body, people with different needs. They hadn't been educated, so I was the only person in a wheelchair in the entire school. And I was not the disabled person that they had been accustomed to or that they had in their imagination, because often motor disability was very often associated with the fact that you are slow, you can't really do anything, and that you're a burden. So to them, that's what I symbolized. And I really did feel this way sometimes. I was always really good in school. I liked to study, to read, to draw, because I had a lot of free time, and that's what I would do. And it was obvious that because I liked all of this, I was good at school. And instead, my peers were very jealous of my good grades. They couldn't understand why I was doing better than them. But because I'm very, very stubborn, and I'm very proud, a very proud person, this didn't prevent me from forging ahead. I never stepped back because I feared my friends' jealousy or my classmates' jealousy. But these were just initial difficulties with my peers. Instead, in middle school, I had a problem with one teacher in particular who had decided that because I couldn't do physical education like all the other children, I could describe how wonderful it is to be able to throw a ball, which I had never done, so I didn't know how to do that. There was a lot of discussion, a lot of fighting against discrimination. And what I can say is that I think it's really important to talk and to raise people awareness as to the fact that it's important to recognize diversity. It seems like very remote as a concept if you don't know anyone who's disabled, but I think it's important to understand that this is something that can happen to anyone. As the doctor said earlier, you're not necessarily born disabled. A disability could be provisional, temporary. You could maybe break a leg. So it's important for others to understand that it's wonderful to be part of society like everybody else.
Grazie. E per quanto riguarda l'arte, credo che
But as for art. I think I would have been an artist anyway, you know, independently of anything really. So you might think that I couldn't kick a ball, I couldn't do anything else, therefore I'm an artist. No, I think I would have been an artist anyway. But of course, when I was a young girl, art was a sort of a shelter, and music, of course, art in general, but music in particular, was my own place, my own room, if you wish. But then I'm very happy to say that I managed to make it into a job, basically. Well, of course, musicians' work in Italy is not actually considered as a job, but that has nothing to do, of course, with me. So I'm a songwriter, and I write in English. That is why I use the English word also when I speak Italian. I am a songwriter, and among my projects, I have a duet with my partner. We both write songs in English. Maybe in the near future we'll be also writing songs in Italian, but we're going to start with this one in English. And I've made a small dream come true, because Guido, my partner, helped me produce my first album solo, which makes me very happy. I am very happy indeed of this solo album. We are going to perform in a minute, so in case you like our performance, please come to see me, and I mean you'll find the CDs. So, you want to take a message? Well, of course, I agree with the messages the boys have given you. You should never give in. You should never give up. Always keep fighting for your own rights, for what we like. And I'm very happy to hear these distinguished colleagues talk about the need not to give up. Thank you. So you have mentioned a project that has to do with your own achievement, but that was basically due to your wish never to give up, which might almost sound impossible to some of us, but that was a spoiler. You're going to see her perform in a minute. Anyway, any questions before that? Any questions from the floor, from the audience? Monica? You seem to have raised your hand. The staff members are getting a microphone, so here you are. Mic is on. So, one of the things we were more sorry about when talking about discrimination of external approach to disability is that our DMD boy at school or anywhere else did not actually respond to the idea of a disabled person that people seem to have, you know, the kind of person who is always there on his or her own. Well, he came home and told us everything about what had happened at school or anywhere else. So very often this has taken us into actual conflicts with, school managers or the people in charge of other groups where he was. I don't know whether other families have experienced this. I mean, disability is already an issue in its own right, but then our children's disability does often not correspond to the idea that people have of disability. So they are like not animated persons. Okay, you are a disabled person, so I know what you should do. But I mean, if I am a disabled person and I need to go to the toilet and I kindly ask you not to carry me there in your own way, you should respect that because I'm a person beside being a disabled person. Sometimes disability is wrongly viewed outside, and that's another issue. Hi, my question is to the songwriter, Veronica, Lulu. Okay. So, I can see you are a successful woman, one who has already won several challenges. What do you think of your own family? I mean, have your family members helped you achieve this? Thank you very much for your very good question. Well, actually, I have had several experiences abroad. That was very important and meaningful also for my own family, because at the beginning, my disease was not very well known in Italy, so I was operated on mainly abroad and specifically in France. So I believe that medical education and education in general regarding disability and the way it should be approached, that is employed and embraced in another country, definitely an advanced country, more advanced than our country already 30 years ago. Well, that was very helpful for my parents. They felt like that was the end of the world, but then they felt that that was not actually the case. And, the disease was not supposed to only be an obstacle. Of course, if health-related conditions are good, generally speaking, then we are called upon to actually trying and overcome those difficulties. We need to be able to manage our frustration, not to be able to do something. But suppose I can't attend an acting course or a dubbing course because there's no ramp or there's no lift. Well, that is a problem that can have a solution. It has nothing to do with people's, mindset. And as far as my parents are concerned, more specifically, well, they felt like if something could be achieved somewhere else, well, then it could be achieved also here in this country, which was a good, teaching for me. There are technical difficulties, of course, but I mean, as Daniele said, why shouldn't I go back home on my own as all the other, my other classmates do? So, if a difficulty can be overcome, it's okay. Difficulties are more often than not in people's mind. But thank you for your question. Any other questions? Or maybe remarks? Anybody from the panel wishing to take the floor? That is not the case. So we are ready for the performance. Thank you all. We'd like to thank our speakers. That was a very interesting roundtable. We have really learned a lot. We'll have to stop right now, of course. Speakers are requested to leave the stage here, and our Lulu will come to the forefront. Thank you.
Ok, grazie. Ovviamente riempio questo spazio ringraziando i nostri sponsor Diamond, Italfarmaco, PTC Therapeutic.
Thank you very much to our sponsors. I'd like to thank all our sponsors because they are behind this performance, so we wish to warmly thank them. We believe it is important for us to have some leisure time too, you know. By the way, this is the result of the challenges that Lulu has met so far.
Eccomi qua. Sassa, prova, prova, prova. Ehi, ehi, ehi. Ok, mi sentite? Si sente forte e chiaro? Ok. Noi non abbiamo riferimenti sul palco, quindi come viene, viene. Sì. Ehi, ehi, ehi. Ok. Allora, direi che è il momento di presentare un po' meglio questo...
So it's time for us to introduce ourselves a bit better. So, as I said, I've worked at this project with Guido. This is Guido, by the way. He has produced this solo album that is my first one, but we also have a band. So just try and imagine a whole band, you know, behind us. You're going to listen to a few songs that I wrote. I mean, I've written, in these 10 years, and the songs I usually write are love songs, because love is particularly inspirational for me. Well, they've often asked me, are your songs about a disability? No, not because it's not a relevant topic, of course, but because it's not that inspirational to me, is it? Maybe one day, who knows, who knows. Well, there are more interesting things than disability, I believe. The lyrics in my songs are usually quite sad, I must admit to that, but the ukulele, you know, makes it particularly cool. So, since you might not understand all the lyrics, just imagine that you are on the beach, it's a sunny day, no problems, no worries.
Anche perché alla Hawaii, ma di che te vuoi preoccupare? Cioè, sinceramente, no?
What should your worries be? I mean, if you're on the beach, you know, in Hawaii. So, the first song you're going to hear is the first one in my album, actually, the first in the list, and it's about people trying hard and making, and maybe not making it.
I just want to be free. My Grazie. Mi serve un attimo, un momento l'acqua. Ce l'ho. Ecco. Scusate, mi serve un momento l'acqua che sto...
Sorry, I need some water. It's hot in here.
Sono troppo vestita per gli Hawaii, cioè decisamente.
My dress code is not exactly the one right for the Hawaii, beaches. And I need a cocktail anyway.
Allora, la prossima canzone si chiama This Wind. Ed è...
So, this is my second song. I wrote it about the change, about change. Sometimes there is a wind conveying change. We don't really know where it's going to take us, but sometimes you'd better just, drift away.
Grazie. Grazie davvero. Comunque trovate la nostra musica.
Okay, so you can find our music online. It's for free. But of course, in case you want to support us, there are some gadgets and of course our CDs that you may want to buy after the performance. That's it. Oh, okay. One more song and then lunchtime.
that makes me feel better. The sound of your voice, because I've been heard. This voice in my dreams. You sing in my nights, but I know that's not real. Love me or don't love me, you ask me tonight. I can't, oh I can't, but I won't say goodbye. Maybe I should kiss you this time, but I know it's just a dream. I wake up when you turn up Maybe I should kiss you this time, but I know it's just a dream. I wake up when you turn up the Love me, don't love me. 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 Grazie. In realtà, guarda, è tutto merito suo. Veramente.
He's the one to be given a big hand to, you know. Thank you. Thank you all. I'm really excited to be here. Thanks for having me. And now have a nice lunchtime. Enjoy your lunch. Well, thank you. So we'll meet again soon. But now, thanks for taking us into a dream. But now it's time for us to have lunch. Lunch boxes are outside. We'll meet again at 2:15. Be on time. Please be on time so that the conference can start again. So, at 2:15, we're going to have a session on affectivity and sexuality, whereas at 2:30, a session on supplements will be held at the Sala Bergamo. Thank you.
Bellissimo.